Shall I start?
1 second, sir. I'll tell you. Introduce me, sir. Hello, everyone. On behalf of ICLA, we welcome Dr. Vikram Bhudoria, sir. Sir is a novel doctor in Mohali, currently associated with Max Hospital. He has 10 plus years of relevant experience. He specializes in both clinical dermatology and cosmetology. Today, he would be speaking on role of Omalizumab in chronic idiopathic urticaria. Thanks, doctor, for joining me. Over to you, doctor. You can start.
Thank you. So, yeah. So, thank you for the introduction. I'll be covering just a second. Let me minimize this. Role of Omalizumab in chronic spontaneous urticaria. I'll be your speaker for today, Dr. Vikram Bhudoria. I'm currently practicing as a consultant dermatologist in Max Hospital, Mohali. So first, let's understand what is urticaria. So urticaria is derived from a Latin word, urtica, which means to burn, because patients sometimes have burning and intense itching or hive. So as per definition, urticaria is a dermatological disorder which is characterized by sudden appearance of itchy hives or wheals, angioedema, or both. And they usually resolve within hours, and they should always resolve by 24 hours. If they stay for more than 24 hours, then we should think of some another disorder. Urticaria is broadly classified into acute urticaria if symptoms are less than 6 weeks, and chronic urticaria if symptoms are more than 6 weeks. Chronic urticaria is further divided into either spontaneous if there are no triggers, or inducible if it is induced by either heat or by cold or by pressure or by skin stroke in dermographism. So the incidence or prevalence of urticaria is obviously much more common in acute urticaria. It's almost, as per various studies, it's roughly around 15 to 25%, whereas chronic urticaria is 5% and chronic spontaneous urticaria is 1%. The incidence rate of acute urticaria is similar for both men and women, and they can occur in any age group, whereas chronic urticaria being also have idiopathic and autoimmune etiology is more common in females and usually seen more commonly during 4th or 5th decade. How do we diagnose urticaria? It is mostly a diagnosis by clinical features and history, and we don't need to do a test to diagnose the disease, especially in acute urticaria. But in chronic urticaria, sometimes to find out the trigger, we go for a test for infectious disease like sinusitis or urinary tract infections, autoantibodies to find out whether it has autoimmune trigger, so autologous skin serum test to specifically done for chronic spontaneous urticaria, and skin biopsy if urticarial vasculitis or some other diagnosis we are suspecting. Regular routine tests which we usually do are CBC, ESR, TSH, IgE levels, which are very commonly done in chronic urticaria, and nowadays vitamin D also. So how do we reach to the diagnosis of chronic spontaneous urticaria? If there is no presence of any autoinflammatory disease or cause for these wheals and pruritus, if the average wheal duration is less than 24 hours, and if the symptoms are not inducible, only these 3 criteria are met, then we can reach to the diagnosis of chronic spontaneous urticaria. So Ig levels are very commonly done in chronic urticaria, and they are IgE level is a very valuable marker, because Ig levels is not always raised in these patients. Only 50% patients they have raised IgE levels, whereas other half has low or normal Ig levels. Now, how do we interpret the levels of IgE levels? So if IgE levels are high, that means the disease activity is pretty high, and they have a longer disease duration, and they fall into this type 1A autoimmune chronic spontaneous urticaria. So such patients are have higher chances to respond to Omalizumab treatment, whereas lower IgE levels point towards type 2B autoimmune chronic spontaneous urticaria, and they have less chances of responding to Omalizumab and better chance to benefit from cyclosporine treatment. So thus IgE level is a very valuable marker in deciding, in planning the treatment for the patient. So there are two scoring systems which we use in urticaria, and most of the outcomes which for the treatment which we give are usually assessed on the basis of these scoring system. One is the urticaria assessment system score, and other is urticaria control test. So urticaria assessment score is basically, there are two parameters, wheals and edge, over a period of 7 days, and it ranges from, the value ranges from 0 to 42, 42 being the most severe, and 0 means very well controlled disease with very low activity. Whereas UCT or urticaria control test ranges from 0 to 16. If the score is 16, that means disease is complete, under complete remission and complete control. And if it is less than 12, that means a poor control of the disease for the treatment given. So what are the treatment guidelines for chronic urticaria? So both US guidelines and European guidelines are kind of similar, with the mild or moderate differences. So as per European guidelines, if newer generation of antihistaminics are not responding, we can upgrade the dose up to 4 times. And if still after 4 weeks there are no control, we should either switch to Omalizumab or Cyclosporine, or should add Montelukast. In between, corticosteroids can be added for maximum of 10 days if there is any exacerbation. Whereas as per US guidelines, we should always start with the monotherapy of second generation newer antihistamines, non-sedating. And at the same time, we should avoid the triggers and relevant physical factor for urticaria. If there is no good control, then either we should increase the dose up to 4 times, or add another second generation antihistamine with that. Or we can add H2 antagonist, or we can add leukotriene receptor antagonist, or first generation antihistaminic to be taken at bedtimes. If patient still does not show results after 4 weeks, we can add older antihistaminics twice daily. Or if again patient is not showing results after 4 weeks, then we should consider either Omalizumab or Cyclosporine or other immunosuppressive drugs. At each level, we need to assess the control and patient tolerance and efficacy. Either you need to step down or step up as per patient's tolerance and efficacy. So very briefly, we'll touch antihistamine. We know there is a very strong recommendation for the use of the newer generation of anti-H1 antihistamine in urticaria over older generation antihistamine because of anticholinergic and other side effects. And commonly used antihistaminics in India are desloratadine, fexofenadine, levocetirizine, and even cetirizine sometimes. So now coming to drugs which are mainly in discussion for this presentation is either Cyclosporine or Omalizumab. So when we compare Cyclosporine with Omalizumab in a study done in 2015, we can see the clear of symptoms when patients were given Cyclosporine and Omalizumab. Omalizumab is way ahead. Almost half of the patient, they show clear of symptoms, and only 17% of the patient showed clearance of symptoms with Cyclosporine. But more important is the DLQI index. So there is 90% improvement in 64% of the patient taking Omalizumab as compared to 18% in Cyclosporine. So DLQI is very, very important in urticaria. If patient have more than 90% improvement, that means the disease is very much under good control. Coming to safety, the dose which we usually use is between 2 to 4 milligram per kg per day. And we do get 2/3 or 1/3 of the patient getting adverse effect to this dose, mainly hypertension, abnormal creatinine clearance, and that's why we have to regularly monitor these blood parameters. Headache and GI upset is quite common. Now coming to Omalizumab. Omalizumab is a humanized monoclonal antibodies against IgE, and it was licensed in 2014 for the treatment of patient with antihistamine refractory chronic spontaneous urticaria in adults and adolescents more than 12 years. So it selectively binds to the C3 domain of the IgE heavy chain, which is the binding site of IgE to its affinity, high affinity receptor. And thus it inhibits the binding of IgE to its receptor on the surface of mast cell and basophil, which thus leads to the decrease in these receptor on the cells, and then subsequently resolution of the results, resolution of the symptoms. So as per recent study done in 2018, there are a few predictors of favorable response to Omalizumab. And these are if patient has not taken any immunosuppressive drug prior to the starting of omalizumab, and the disease duration is very short. There is no angioedema, and the anti-histamine release test is negative, or if there are a higher level of IgE. So in real life practice, what is the starting dose and whether we can prescribe 150 will come to these questions later. So when we give omalizumab, there are a few terminology we should be aware of. Like some patients are fast responder, that means they respond very fast within 4 to 6 weeks. Some are slow responders, which those who respond after 12 or within 12 to 16 weeks. But if patient does not respond after 16 weeks, then that means patient is a non-responder. Complete responder, if there is a urticaria assessment score of 7 is 0 and there is absence of symptoms or angioedema, and patient does not require any H1 antihistaminics. Good responder, where US score usually remains between 1 to 6, and partial responder if the US score is between 7 to 15. So as per trials done and real world evidence, you can see through this graph or chart, 300 milligram dose in a month gives much more better response, good control over the disease as compared to 150. So answering the question whether 150 can be started. So 300 is the actual dose where even after certain doses, the urticaria assessment score, we get good control and come to 0. So what is the Indian experience with omalizumab? In a study, it's a study done in 2018 where they included 24 patients, and they have seen that they have given only once a month 300 milligram dose for 3 months, and then they followed the patient for 6 months after the last dose. So as you can see, just with 3 doses once a month, 50% patient had a satisfactory response, whereas 25%, which is quite significant, 1/4 of the patient, they did not require any antihistamine after 3 monthly injection of omalizumab, even after 6 months, and only 4% were non-responders. So disease-free days was seen at the end of 3 months was 60% of the patient, and 10% responded relapsed after 9 months. Well controlled, that means urticaria severity assessment score 1 to 6. Almost 70% of the patient they fell into this category after 9 months, and mild urticaria only 20% at the end of 9 months. Another Indian study where they actually gave only single dose of omalizumab in 4 patients who were not controlled with 4 times of the dose of antihistaminic, and also 2 patients did not show good response even to cyclosporine. So as you can see, out of these 4 patients, there was sharp decline in the urticaria assessment score and DLQI within 7 to 10 days, and it was maintained up to 4 months in one case and 20 weeks in another 3 cases. So both the scores at the end of the follow-up period of 24 hours were better than the pre-omalizumab scores, just with a single dose. So again, the same study, as you can see, by the end of 20 or 24 weeks, they started getting those original or lower urticaria assessment score. There was this single case report in which a 45-year-old female, which was suffering from chronic urticaria for 10 years. She was not responding to cyclosporine, antihistaminic, and montelukast. So after first injection, she showed more than 90% control of her urticaria, while after the second injection, she had the total relief from her symptoms, and it lasted for 4 weeks. Both 300 milligram dose once a month or twice a month were also tried in various studies, but as you can see, the results almost remains the same. So once a month is enough dose. So how to adjust the dose of omalizumab? So if patient is under good control, or if patient is not under good control, so you can increase the dose up to 600 milligram per month instead of giving 2 doses. Most of the study shows that 600 milligram dose given once a month is more effective. And if you want to reduce the dose, there are 2 ways. Either you can increase the frequency. I mean, instead of 4 weeks, you give it 5 weeks and wait for 2 weeks. If they're good control, then you can extend it to 6 weeks. And if till 8 weeks patient does not get any urticarial rash, you can withdraw the injection. And in other way is decrease the dose to 150 milligram for 4 weeks, wait for at least a good 6 months, and then you start increasing the frequency again. So after withdrawal, what is the remission rate, and should we continue antihistaminic? So yeah, depending upon the disease control, it depends on the physician whether they need to continue the antihistaminic or whether they need to reintroduce the antihistaminic. That depends on the urticaria assessment score. So as per this flow chart, you can see if there is no response within 3 months with the Omalizumab, you should withdraw Omalizumab. I mean, there is no point in giving Omalizumab for more than 3 months if there is no response at all. You can increase or decrease the frequency and dose as per patient, and reevaluate. If patient does well on the lower dose, you can maintain on lower dose. If patient actually get worsening of the symptoms with lower dose, you can bring back the patient to 300 milligram dose. So what are the adverse effects? So one of the major studies done on Omalizumab by Dr. Moria et al. Over 323 patients. So they have given multiple doses and they have compared with placebo, 75 milligram of Omalizumab, 150 and 300. So they have seen only 9 serious adverse effects, out of which only 5 were from 300 milligram group and 2 were from the placebo group. So for 75 milligram of Omalizumab group, only influenza-like symptoms and headache are more common. Obviously, urticarial rashes, worsening and urticarial rashes are common in almost all the groups. And with 300 milligram group, the tiredness, malaise, musculoskeletal pains, and discomfort and more neuropathies and urticarias are common, but there are very few patients are seen, one patients. No deaths were reported in this study, and there were only 2 cases who were fulfilling the Sampson criteria for anaphylaxis were seen. Another study by Dr. Kaplan et al., which included 552 patients of Omalizumab and 84 patients in placebo group. So headache and upper respiratory tract infection were common in Omalizumab group, whereas urticaria, migraine, and congestion were common in placebo group. And the frequency of anaphylaxis was about 0.2%, which is quite negligible. So to summarize today's presentation, I would say Omalizumab is a very safe but effective treatment option in patients which are very difficult to treat, and where we don't want or we cannot give cyclosporine or other immunosuppression. Omalizumab should be considered in patients of chronic spontaneous urticaria. Thank you.
Sir, we had a couple of questions in the chat box.
So chronic inducible urticaria or chronic idiopathic urticaria is chronic spontaneous urticaria. Is mostly the common cause is antibodies seen and autoimmune phenomena. So yeah, they respond better to Omalizumab as compared to other chronic urticarias like inducible urticaria, even though it has been shown in many studies that inducible urticaria can be treated and shows good response to Omalizumab. What are the challenges in the treatment of chronic idiopathic urticaria? Because these patients are suffering from many months and they have almost tried every possible treatment. So we need to maintain them and we need to gain their trust while giving the treatment. And I mean, because they want complete remission of the disease. So which is the main challenge, because patient, the main factor which actually affects the psychology of the patient is that they try to isolate themselves because there is a sudden eruption of the urticarial rashes and that makes them uncomfortable. So yeah, complete remission are actually for long period is required in such patients. So yeah, we have already discussed that Omalizumab binds to the receptor of Ig binding site on mast cell and basophils. So that actually decreases the concentration of these receptors on these cells, and thus when the concentration of these receptors comes down, the possibility of getting severe reactions are much less. What are the current clinical trial outcome for omalizumab in treatment of current showing good results, and earlier it was fourth or fifth line of treatment, but now because of the many recent clinical trials, nowadays it is more preferred drug, and even as per few guidelines, they should be considered as a first line treatment in chronic patients. I would say, as we have discussed in the presentation also, clinical trials still show a decent enough result, but in real world results are much better, and response, most of my patients, they are doing pretty well. And I usually withdraw antihistaminic after 2 doses and tend to see whether the patients are doing well. So yeah, real world evidence is in the favor of omalizumab. Common side effect: flare-up of flare-up of urticaria is the most common. Injection site redness, pain is another, and they are very easily manageable. We just need to upgrade the dose of for the first 2 doses. After that, patient usually gets good control. So yeah, overlap it with antihistaminic. So the test which I have recommended, that IgE levels and ESR, CRP, inflammatory markers. So all these tests help us to figure out whether, and yeah, if patient is not responding to 4 times the dose of antihistaminic, so in such patient, they are the good candidate for omalizumab. What is the appropriate dosing regimen for omalizumab? So yeah, response how to monitor response is clinically the Urticaria assessment score or UCT. So dosing regimen, I always start with the 300 milligram of dose, depending on the weight. If patient is overweight, like one of my patient, she was above 100 kg, so I started her on 450 milligram. Otherwise, 300 milligram is enough dose, and 300 milligram once a month can be safely given, can be upgraded or downgraded depending on the response. Advancement, more and more pathophysiology we are understanding. So more and more, biologicals are already in pipeline for urticaria. So that is what I'm aware of right now.
That's it. The questions are answered. Thank you so much, Doctor, for the excellent presentation. And I would like to thank all the participants who joined the webinar. Thank you so much.
Thank you.